Hello everyone, welcome back to Mid Sound Bites. Today we will talk about pharmacodynamics. Pharmacodynamics is what the drug does to the body. It is associated with three important basic terms, which is affinity, efficacy, and potency. Affinity is the tendency of a drug to bind to a target. The tendency of a drug to bind to its target is what is the affinity. Affinity's dose is required to bind to a target, right? So a certain amount of dose is required for that drug to bind to the target. So dose is important in terms of affinity. Then we talk of efficacy. Efficacy is the maximum clinical effect that is produced by a drug. So here we're talking about, in respect to the clinical effect, the maximum clinical effect that the drug can produce. Now, efficacy is the effect produced is what will tell us about the efficacy, right? Because we are talking about its clinical effect in the body, and whatever is going to be the effect will tell us about the efficacy of a drug. Now, this effect that is produced, so efficacy is something that is more important clinically, right? Then we have potency. Potency is relative dose of a drug required to produce a particular effect. Whatever is the relative dose of a drug that is required to produce A, B, C, D, X, Y, Z, some effect, to produce a particular effect. Now, potency will always be inversely proportional to a drug. If I am taking a drug which is 20 milligrams and it's doing its action, and at the same time there is 50 milligrams of drug that is doing the same action, of course the one that is 20 milligrams is more potent, right? So the lesser is the dose, higher will be the potency. So potency and dose have an inverse relationship. Then we have the dose response curve. Now, dose response curve is of two types, quantile and graded. And if we talk of in here, quantile dose response curve is usually in a population, and it's binary, either yes or no type of thing, and it is associated with terms like effective dose 50, then there is toxicity dose 50 and lethal dose 50. So the lethal dose 50 is something that is only for animals. It's the dose that is required to kill 50% of the animals, and it was a marker of the toxicity of a drug. And toxicity dose 50 is of course the dose that is required to produce toxicity in 50% population, right? And it is also a marker of toxicity. Now, effective dose 50 is the dose that is required to produce effect in 50% of the population. So this will be a marker of a potency of a drug. If we talk of the graded dose response curve, it is graded and it is in an individual. Here we are looking at the efficacy, potency and affinity, right? So the taller you can when you look at the graph, the taller is the graph, it means the more efficacious that drug is. So that we say height of the graph is going to tell us about the efficacy of the drug, right? The clinical effect that the drug produces. The potency is associated with the line which is closer to the x-axis, of course. Right, and affinity will be checked only can only be compared only if the drugs act on the same target, right? So in the DRC, the dose response curves that are going to be parallel, only for them we will be able to compare the affinity, and the ones which are not parallel, of course we're not going to compare, because it simply means that they're not acting on the same target. So we just look at the we compare the lines which are parallel, right? Further moving on, there is a therapeutic index. Therapeutic index is it's the toxic dose 50 over the effective dose 50. And if we will talk in terms of animals, then the toxic dose 50 of course will become lethal dose 50, right? It is something that that's a measure of the drug safety range. It tells us about what? It tells us about the drug safety range. And there's a thing called therapeutic window, which is between the minimum effective concentration and the minimum toxic concentration. Now, minimum effective concentration is the effect that is like it's the minimum effective concentration is like the minimum concentration of a drug that is required to produce a certain amount of effect, right? So the effect is going to be seen only beyond this minimum effective concentration, and the minimum toxic concentration is the toxicity which is going to begin beyond this minimum toxic concentration. So just in between this MEC and MTC, what we have is called as a therapeutic window. Further, we move on to drug receptor interaction, guys. Here we have full agonists. So full agonist means they're going to produce a maximal effect. They are agonists, and partial agonist will produce a submaximal effect, right? If it's antagonists, which are the most common, it does not actually produce any effect. There's no effect in terms of antagonism, and inverse agonist will be a opposite effect. Now we have also certain types of antagonism, but the most important here is competitive and non-competitive antagonism. So competitive is antagonism is there, and then there is non-competitive antagonism. So with the competitive antagonism, we need to understand that when a drug and its antagonist is added, there is going to be a right shift of the dose response curve. That is that we have to increase the dose of the drug if antagonist is given in competitive antagonism, if the antagonism is given along with the drug. We are talking of competitive antagonism. Here the efficacy of the drug is going to remain the same, right? The efficacy is not changing, the height of the graph is not changing, the Vmax remains the same, but the potency of the drug definitely is going to fall, and the Km value will increase, right? Because it's the substrate concentration at which 50% of the Vmax is attained, and this is going to increase since we're increasing the dosage. If we talk of non-competitive is where we will see a decrease in the height of the DRC curve. We will see a decrease in the height, and the potency and Km will remain the same because now we're not changing the dose or something. Here what is going to fall is going to be the efficacy of the drug, right? Efficacy is going to fall, and Vmax is also going to fall. This is what happens in non-competitive antagonism. Further, moving on to receptors, there are ligand gated ion channels like glutamine, GABA, 5-hydroxytryptamine, nicotinic. Then there are nuclear receptors. Nuclear receptors are located in the cytoplasm, or the ones which are located in the nucleus. The ones which are located in the cytoplasm are vitamin D, androgen receptors, mineralocorticoid, and glucocorticoid receptors. The ones which are located in the nucleus are thyroid receptors, estrogen receptors, and progesterone. If we talk of enzymatic receptors, these are tyrosine kinase. Very essential to remember in this is insulin, along with IGF-1, toll-like receptors, and epithelial and vascular endothelial growth factor receptors. Janus kinase receptors is our leptin, growth hormone receptor, and prolactin. And finally, the guanylate cyclase receptors, which is our ANP and BNP. Then there are G protein coupled receptors, of course, where we have GS, which is working via the adenylate cyclase, increasing the CAMP and causing smooth muscle relaxation in cardiac muscle and skeletal muscle contraction. It is a beta 1 receptors, beta 2 receptors, beta 3 receptors are GS subtype of it. Now we say that GQ stimulates phospholipase C, and it is known to cause smooth muscle contraction, and this is our alpha 1 receptors, muscarinic M1 and M3 receptors are there. Then there is GI, which is going to decrease the CAMP levels, of course, and cause relaxation. So these are the M2 receptors in the heart. There is one more which is called the G12 or 13. This is something that stimulates the Rho kinase. This is something that will stimulate the Rho kinase. So when we talk of drugs, usually we give Rho kinase blockers, like Fasudil is there, or Nitarsudil is there. So Sudils, they are a Rho kinase blocker. Fasudil is something which is used as a vasodilator in stable anginas. And there is one more drug called Belumosudil. Belumosudil is something that is used in graft versus host reactions, and Nitarsudil is something used in glaucoma. Okay. Further, there are trials, of course. Clinical trials are there, and they have got some phases. The first phase is all about human psychology and toxicity study. Here we know about the study about the pharmacokinetics, dynamics, the tolerable doses, the toxicity, and safety. The second phase is where we talk of the therapeutic exploratory trial. This is where the dose range or determination of the efficacy is something that happens. And the third phase is the therapeutic confirmatory trial, where we confirm the efficacy and safety of a drug. Here the drug is approved by the FDA or CDSCO and then is marketed. And the fourth phase is the post-marketing surveillance, where we are looking at the long-term adverse drug reactions in the patients who are already taking it. Right? And there is therapeutic drug monitoring. Therapeutic drug monitoring is the plasma concentration of a drug should have a good correlation with the effects or the side effects. That is how we can know about therapeutic drug monitoring. That is the principle of it is that the plasma concentration of a drug should have a good correlation with the effects or the side effects. Right? The drugs which have got a low therapeutic index are it is aminoglycosides, lithium, theophylline, digoxin, cyclosporine, tacrolimus, and tricyclic antidepressants. These are the drugs which have got a low therapeutic index, right? And then we have some drug, like importantly we should know of digoxin. The therapeutic range for digoxin is 0.5 to 0.9 milligrams per milliliter, and more than 2 nanograms per milliliter leads to toxicity. If we go with theophylline, this is 5 to 15 milligrams per liter is therapeutic range, and more than 15 is toxicity. Lithium, the therapeutic range in mania prophylaxis is 0.6 to 1 milliequivalents per liter, and for mania treatment it's 1 to 1.5 milliequivalents per liter. When it is more than 1.5, it leads to toxicity, and when it is more than 4 milliequivalents per liter, then we have to perform dialysis. Then what we do? Then we have to perform dialysis. There are also some pregnancy drug categories, like category A, B, C, D. A, B, C are the drugs which are safe to use in pregnancy. D is which can be used because their benefits are greater than the risk. For example, we can use valproate if in juvenile myoclonic epilepsies. And category X are the ones which are absolute contraindications. No matter what, a pregnant female should not be taking these drugs. These involve drugs like thalidomide. That's all for today. If you like the video, please do like, share and subscribe to the channel. Thank you everyone, and good luck.